I'm Dr. Sunita Patel from India. I'm a physiotherapist, and today we are having Dr. Sandeep Saili with us, who is a physiotherapist working in Singapore. And we are so fortunate to have him today. And the bridge is because of Dr. Meena, who is Dr. Meena Pushpanathan, who is a very, very senior physical therapist in Singapore. In Malaysia, sorry, in Malaysia. So she is with us, and she's the one person who connected us with Dr. Sandeep. So happy to have you, Dr. Sandeep, with us, and like we are really, really happy that you're going to share this important topic amongst all our other physiotherapists. Thank you so much. We welcome you to the platform.
Thank you. Okay, let me quickly introduce myself, and then we go from there. We have 30 minutes to share some information. It may be, for some people, they already know it. Some may not know it. It can be a refresher for some people who know it. You may add later to others' knowledge as well. What I'm trying to do is to share what I know. If it's a duplication, just absorb it. If it's not a duplication, it may be something new for you to know about. Yeah. So I'm Sandeep. I'm 14th batch physiotherapist from Institute for the Physically Disabled, New Delhi. I graduated in 1987. Then I worked in Sir Gangaram Hospital for 5 years. I moved to Malaysia. I worked there for 1.5 years. Then I moved to Singapore in 1997. So after 10, in 1992. Then 1997, I went to England to do masters in cardiorespiratory physiotherapy. I came back in 1999, lived there for 2 years. Then I joined my hospital back because I was bonded. I started cardiac rehabilitation program and pulmonary rehab program. I still teach in National University of Malaysia. For last 7 years, I've been teaching. Other than that, I have many other different aspects, different interests. We also have a company which sells physiotherapy equipment in Singapore, Malaysia, and Thailand. So I travel very often in this region. So that's how I know Miss Meena, because we have employed some of her students. She was heading School of Physiotherapy. It's called Saim Darby School of Physiotherapy. She was the principal, the dean of the school. So that's how I know her. Okay, let's start. I'll share my screen. Give me a second. Let me open my screen first. All right. There you are. I hope everyone can see my screen. Okay, so today we are going to discuss about electromodalities in incontinence and erectile dysfunction. I'm sure this topic is pretty interesting for the reason that we know a lot about incontinence and physiotherapy. We know about pelvic floor dysfunction. We know about how to do pelvic floor training, Kegel exercises, weights, electrical stimulation, vaginal probes, erectile probes, what we use, electromedical modalities. What I'm going to introduce today is a little similar, but slightly different, or maybe what has come into physiotherapy recently, and a very new, totally new topic for some of you is erectile dysfunction. I have grown interest in it, not because I'm getting old, but because we have come across the technology which it may open a channel for physiotherapists to expand their field of practice, because this is open now. At the moment, it's absolutely open. Urologists do it, rehab physicians do it. There are some people, those who are non-clinician, also doing erectile dysfunction. Men's health clinics are coming around everywhere in Singapore, Malaysia, Thailand. So I think we should look at it very, very seriously. If we if we are keen, I think this field is for us to grab because it uses electromodalities, and we are all using electromodalities for many other conditions like muscle functions, for pain management, for strengthening, for endurance, and many more things. So let's see what do we have for us in offing. And I think we have something to contribute to medical field or paramedical field if we get into erectile dysfunction. Okay. Uh, Let me start. We only have 30 minutes. I will finish it by 8 o'clock in India time, on time. So I'll go pretty quickly. With advancement of technology, electromodalities are quickly changing. You know, when I was trained in 1984, there was my 14th batch. We had electrotherapy, we had ultrasound, we have paraffin wax bath, had infrared lamps, ultraviolet lamps, shortwave diathermies. Somebody introduced microwave diathermies. We were the first hospital in 1987 to have a low-level laser therapy, and we were super excited. We knew nothing about it because it was never in our training program. It was not in our syllabus when we were in school. So we had no idea what to do with it, how it works, what is photobiomodulation. We had no idea, but we knew we had laser in our clinic in Sir Gangaram Hospital. But with time, the technology has changed and we must adapt. If we don't adapt, we will lose out. These are the incoming technologies which we are seeing more and more being used, at least in our area, our region of the world, in Singapore, in Malaysia, in Thailand. Radial shockwave, I'm sure you are familiar with this. Another incoming modality is focus shockwave, and I'm going to talk about focus shockwave today. High power lasers, a lot of people still don't know the difference between low level laser therapy and high power laser. How do you differentiate? Because it was not in our syllabus, and it's still not in syllabus of my university where I'm teaching, because it takes time for books to get literature, someone to write books, get approved in the university. So a lot of new modalities are still not part of curriculum in the universities. So whatever I'm telling you is all acquired knowledge. People are learning from here and there, going to PubMed, finding literature, coming into practice, because there are a lot more new technology, new equipment coming to your clinic. Superinductive therapy is also called PMS, peripheral magnetic therapy, magnetic stimulation, coming very, very popular in our area. Augmented reality, virtual reality, this is a field to explore. You can do a lot of stuff with this, like rehabilitation, balance training, stress management, a lot of things you can do with this. And what is becoming is exploding is robotics, artificial intelligence, and brain computer interface. That's not the topic of my discussion today. I'll keep to my topic today, which is, as you know, incontinence and erectile dysfunction. So I'm going back to my first slide. This is where we will focus today. When we have some time in future, maybe we will talk about many other things like high power lasers, how augmented realities are changing practices, and what will happen in next 5 years, and VR as well, and robotics. Robotics are changing how man will be trained with machine. Not that you set up the machine for the patient, but the robot will decide how much resistance you require, where you require assistance. It's all robotics. So very, very interesting field. We are getting into, unfortunately, I find myself born a little earlier. I hope I was born like 20 years later, I would have enjoyed this incoming technology more. But the field is changing very, very fast. So let's go to this exciting phase of our clinical practice as well. Okay. So incoming technologies will transform practice. It will bring more. If it has not transformed the practice yet, it will. It will bring more expertise and specialized practices. Like people have musculoskeletal, cardiac rehab. You may have a robotic clinic. You may have men's health clinic. You may have only incontinence management clinic. As Dr. Sunita, I see that she's really expert and she's been doing a lot of talks on incontinence. She's promoting something very interesting, and I believe and I hope many people take this as a specialty of their clinical practice and open more and more, because more we do, a lot of more people will know about what we can do. Um, so we'll continue to learn and transform our practice as more technologies come in. It will and may improve healthcare. So I don't know, it may. Definitely healthcare will become more expensive. We can't avoid that with more technologies coming in. I have an advice for physiotherapists in that sense. You know, a lot of people are aversive of technology. We shouldn't be, because you look at doctors, they are really good orthopedic surgeons in our hospital, but they are still using robotics to perform surgeries. Why do they use technology? Because no, they know they can get patient better faster. So having manual practices, doing manual therapy is great. I think you should continue to do that, but do not ignore the things happening around you in terms of technology, because this will transform medical healthcare. So I believe more people will, pay a little more attention to what is happening. I'm not promoting that you should use them. That's not what I'm saying, but I'm saying let's be aware of what's happening around us. One day we might find ourselves way far behind with things which have changed. So let's do it. So topic of today's discussion is incontinence management using superinductive therapy. It's also called peripheral magnetic stimulation, and erectile dysfunction using focus shock waves. I think some of you may know, or 80% of you may know about superinductive therapy. 80% of you may know about focus shock wave as well, but let me do a refresher if you know about it. Okay. Right. So what is superinductive therapy? This is magnetic stimulation. It's similar to what we have electrotherapy. That means like electrical stimulation, but this electrical stimulation is generated by electromagnetic field. Anything comes in between this field, in the sphere of this field, will be influenced by this field, and muscles start to contract. Okay. So in this coil, what you see here, this coil generates an electromagnetic field. If I put my hand around this, it will start to stimulate, and you don't need to stick electrodes on the skin. Okay, that's something good about it. So if patient doesn't want to take off clothes, you want to do it above the clothes, no problem. Reason being, this is not absorbed by clothes, by bones. It goes to soft tissues. So it does a good, and also on nerves, depending on, I'm not going into the specifics of how it works. Maybe some other day we will talk about it, that how the technology works. But for today, what I would like to say is an electromagnetic stimulation where energy positively influence human tissue. It has function in repair of the tissue, strengthening of the muscles, and pain management. The inductive coil, the coil in this particular area of the machine, what it does is the coil generates pulses. So there are pulses coming out from this. The electromagnetic field interacts with the human body. It causes depolarization of neuromuscular tissues and cell membrane, similar to what you see depolarization with electrotherapy, like electrical muscle stimulation. But the therapeutic effects are determined by frequency and the intensity. So just remember that this is similar to electrotherapy, but it's created by magnetic field. You don't need to stick electrodes. Now, this is the coil. This is the skin. These are fats. This is muscles. So what happens when you apply PMS or superinductive therapy? What it does is it goes 7 centimeters deep. So it goes through your fats, it goes through your muscles, it goes even further down. So why I'm talking about the depth, why I'm talking about PMS, why I'm telling all this is because you can stimulate pelvic floor muscles without a vaginal electrode, without an anal electrode for anybody you would like. So this is such an interesting technology where you can see your pelvic floor moving. So if you practice real-time ultrasound, if you are familiar with real-time ultrasound where people train everybody on RTUI and let them see their pelvic floor moving, I think you can combine it with PMS with real-time ultrasound to see how your pelvic floor is moving. I think this is something we should look at in terms of technology for deeper penetration. So 7 centimeters deep. So it's a non-invasive method of delivering rapid pulse, high intensity magnetic field to the periphery other than brain. So you can't use this for brain. This is called peripheral magnetic stimulation or superinductive therapy. For brain, there is another specific magnetic stimulation. It's called TMS. It's not PMS. So that's transcranial magnetic stimulation, also becoming very popular for pain management and stroke management. I think we will discuss that at some other day, but it's important to know what is available around us. So a changing magnetic field induces an electric field, which in turn creates an electric current to the targeted tissue. This is what we are looking at when we want to stimulate a muscle. Okay. It has many functions. It can do relaxation of muscles. In fact, there are good studies done with this that it helps in reduction of spasticity. If you apply at the spinal cord level, and there are brilliant studies available. You apply at the spinal cord level for patients, those who have incomplete spinal cord injury, and they have um, increased tone spasticity. If you apply it, it keeps the spasticity lower for next 48 hours. So you can continue to do, contraction of antagonists to make them stronger. A lot of things, but today I'm not talking about how it manages pain, how it works. I'm only going to focus this technology on the last part, which is incontinence. Okay, these are the general parameters. Like electrotherapy goes in milliamperes, you go by 10, 15, 20 milliamperes. Electromagnetic stimulation or PMS, it goes by energy. It goes by Tesla. So that's the unit of energy used in this, and it has a frequency for 5 to 150 hertz. If you know electrotherapy well, you will know when to use low frequencies and when to use higher frequencies. That's a topic for another day. Okay, I would like to show you this link of a new particular modality available. Let's see if I can play it. If you can see it, please say yes. Sunita, please help. Dr. Sunita, please help me to do that. I'll try and play this video.
Yes, we can see that the link is there.
Okay, can you see my screen?
Yeah, we can. It is visible.
Okay, can you see the video?
Not yet. You have to close this one first.
Okay, okay, give me a second.
Yeah.
Okay, give me a second. I will new share. Okay, yeah. Can you see the screen now?
Yeah, it's visible.
Okay. It's called Conticure.
It's not audible, sir.
It's not audible. You need to unmute yourself, Dr. Sandeep.
Oh, it's not
No,
audible.
can't hear you.
Anyway, just to, it's a short video on, okay. It's a short video on, I can share this.
You can close this and
Okay, so I can show that, I can send this link.
okay.
Okay.
You can come back on
I'll
his.
share my previous screen again.
Yep.
Just wanted to show you how the technology, are you able to see my screen again?
Yeah,
Link to
yeah.
available modality?
It is
Okay.
visible.
Right. So just to give you a little bit of clinical evidence on what has been published recently, for last 5 years, a lot of publication has happened on pulse magnetic stimulation, on stress incontinence, on um, uh, stress and the other, forgetting the term. For say, let's go to the stress incontinence in on impact of on sexuality and health. This is published in 2022. The objective was to evaluate the efficacy and safety of device that uses electromagnetic technology to treat urinary incontinence. They had 47 subjects, 18 to 80 years old. Two pulse planar magnetic therapy was used for 8 sessions in 4 weeks. That means there were 2 sessions per week. This is the assessment criteria: female sexual dysfunctional index and other indexes, including pelvic floor bothersome questionnaire. The results showed the improved result of the treatment group compared with the stimulated group shows that pulse magnetic stimulation is a safe and attractive, non-invasive alternative to patients who prefer non-surgical treatment. So this is published documents. There's another one. This is 1 year follow-up. Why I'm sharing it? Because there was a 1 year follow-up. This is a randomized, double-blinded, sham-controlled study. So pretty powerful study published in Journal of Urology and with 120 subjects. So it's not a very small study. And they have done the follow-up for patients, those who, I think it was for 1.5 years or so, those who had, and they showed patient had 2 sessions per week again for 2 months. That means 16 sessions. And they used this criteria, and they found that people, those who had 32 sessions, showed the maximum result compared to 16 sessions, those who showed 68%. And those who did not receive any pulse magnetic therapy, they only had 21% result with the conventional therapy. So there's an encouraging long-term response rate that shows that pulse magnetic stimulation is an attractive non-surgical alternative for patients who do not want to undergo surgery. Something really interesting to look at, a lot of documents. I do not have time to share all because our time is limited, but I would like you to go to PubMed and look at the number of documents, those who have been published in last 5 years. Most studies are in last 5 years. Some are older ones, but I think as the technology has changed, the publications have also come in with this. Okay, let's look at shockwave therapy. We have only 6 more minutes to go. Is for erectile dysfunction. This is what we are talking about. Let's not mix up between shockwave therapy and radial pulse therapy or a radial shockwave. So there is a focus shockwave and a radial shockwave. For focus shockwave, you have a gun which is like which has a bullet which goes up and down. It hits the skin. When it hits the skin, shockwave radially spreads into the skin. Deeper it goes, lesser and lesser it becomes in its impact. So it starts to getting lost as it goes down. On the left side, if you see, this is focus shock wave. This is a applicator. When it produces a shock wave, it goes and focuses at a particular point. Now this applicator decides where it will focus. It may focus at 6 centimeters, 8 centimeters, 10 centimeters, 4 centimeters, you cannot control the focus. You can only change the depth by applying a thicker or a less thicker the gel in between. So technology is similar, but I think the effects are very, very different. When it comes to shockwave, people get a little worried that, oh, shockwave can be dangerous. You know, the shockwave started with lithotripsy, where doctors used to use it for kidney stone breakdown. Then it went into orthopedics, where it started, doctors started to use it for superficial osteophytes, that's for orthopedic. Then it came to physiotherapy as a radial shockwave for pain management. And this is how shockwave has moved also to focus shockwave. Okay, there's something happening to my screen. I do not know why. Okay, so focus shockwave uh, it's quickly into the body. It's a very short pulse. It's a pulse of a 10 nanosecond, and it's very high pressure bar, like 15 MPa, 140 Pascal. It goes really deep in your body, and it goes and shocks the area where you would like it to be. So this is how the shock wave looks like. It goes like 100 and up to 140 bars. If you compare this shock wave to radial shock wave and the ultrasound, you see how high the pressure bar goes and it comes down. That creates a lot of different things in the body. The mechanism of shock wave working is called mechanotransduction. That means when it hits the body part or the cell, it does some changes in the cell. There are cellular activities which happens. That's called mechanotransduction. I'm not going into it, into the physiology, but this is what to remember, that it does mechanotransduction. There are three different type of generators those who generate shock wave. They are called electromagnetic principle. This is like a indirect shock wave, that this particular module creates a shock wave. This particular module creates a shock wave. It hits the drum, then it goes and focuses on the body part. There is another one called hydroelectric. It also creates a shock wave. It hits the drum and it goes and hits the body part. Some of the shock waves may not go directly to the skin if they are not hitting the drum. So some of them get lost. The better technologies is called piezoelectric shock wave. There are small electric, these are small piezo crystals. They create the wave and it goes directly and then hit the skin. This is how piezo shock wave looks like. This is the drum. It goes and then it targets this tissue. You will see some changes around there as well as too, but this is where it focuses. Now, what has happened with piezo shock wave is there are linear applicators available now. If you look at this applicator, this is piezo, this is the linear applicator. This creates a shock wave linearly along the area, surface of the area, which you would like you to cover. Like you can have a linear shock wave of 44.6 centimeter wide. Now, this is important for erectile dysfunction, because a patient, you can have the patient have it on their shaft and on the curvosum and underneath as well. So this is something which is useful for erectile dysfunction. Though normal shockwave applicator can also be used, it takes a little time. But why should we use shockwave for erectile dysfunction? Okay, as I said, the mechanism of shockwave is to convert mechanical stimulation into biochemical or molecular biological signals, which helps in not only doing helping erectile dysfunction, for many other things, for pain management, for regeneration of tissues, for improving cellular health, something called photobiomodulation. not photobiomodulation, but mechanotransduction. To talk about stimulation of microcirculation and release of nitric oxide, which causes vasodilation, increased metabolism, and angiogenesis. And it also has anti-inflammatory effect. So remember the words microcirculation, angiogenesis, and also vasodilation. When someone has erectile dysfunction issues, they have either psychological issues or they have reduced circulation in their in the penis. So if something which can improve angiogenesis in the penis, it helps them a lot. And I would like to tell you that focused shockwave is the first line of treatment for patients, those who have erectile dysfunction. And there are algorithms available which tells you if how badly patient is affected with erectile dysfunction, and will focused shockwave work or will not work. I can this is done by a urologist called Dr. Motil. I can share it with you later if you like. But today what I want to introduce to you is that erectile dysfunction is the first line of treatment for patients with erectile dysfunction. Okay. Not only erectile dysfunction, there are other fields which we totally, or dysfunctions which we totally ignore. Is called chronic pelvic pain syndrome. Again, the pain is there, so it's a excellent technology for pain syndrome. It's called CPPS and induration penis plastics, so IPP. So, but today we are going to focus on erectile dysfunction. Okay. It's a unique concept when you apply focused shockwave on the penis. It has shown to improve patients, those who have had erectile dysfunction. It needs 6 to 8 treatments. Those who are on Viagra or on sildenafil, they have shown to, again someone has scribbled something, they have shown to improve, and this carryover effect is 12 to 18 months. A patient needs a treatment for 6 to 8 sessions and they improve for 12 to 18 months, and they do not need to have Viagra or any other stimulant for their daily needs. They can be better without it. It in fact has shown to improve sexual pleasure. I'm trying to not promote anything in other sense. I'm talking very professionally and technically. Those who suffer, they know how bad it is. Those who don't suffer, they may find it funny. But this is the field we should look at. This is where we should go. I think this is what we can explore. There is a... Dr. Sunita, you want to say something?
Yeah, I was just saying that this is the field, men's health, where we can definitely help a lot of people, because
Yes.
As per the studies, 40% of people, they have they are having dysfunction, erectile dysfunctions after the age.
They don't talk. Yeah, it's a taboo. Like incontinence is a taboo for men and women. Erectile dysfunction is also a taboo. People do not talk about it. But I think if we explore, we will find there is an opportunity to help people and expand our practice of physiotherapy as well. This is an electromodality. This is what we are using for pain management. We are using for cell healing. Why can't we go into another field and start something new which can be helpful to the society?
And as well as it's our profession also.
Oh yeah, this is close to our profession. We are just expanding our field of of scope of practice, and it's open. No one is doing it except for urologists. No one is doing it. This is something new which is coming in, and we can do it very easily. And this is totally harmless therapy.
And I really want to share here that I'm associated with one clinic in Bangladesh, Impala Pain and Rehab Center. So where we have this modality, shockwave diathermy, and we are treating many patients who have this issue. So very effective treatment it is for erectile dysfunctions. So really want to add here.
Yeah, I mean, published data is unbelievable. It's just that we have ignored it for very long. This is something we should look at. Okay. There are protocols available, number of shocks required. We know energy level, energy flux density we require. This linear applicator, you can have depth of penetration like 10 mm, 15 mm, 20 mm. For Asians, it's different. For Africans, it's different. For no, Far East Asian is different depending on the penis size. So we know how to. I've been doing many demonstrations of this to many of the doctors. So it becomes like a regular practice when you start doing it. It feels funny when I started. I must say I felt funny as well, but I think it's becoming very normal to do it because I have acquired this knowledge, and I think it's very beneficial for people. Uh, if you can see the screen, the top part of penis is called cavernous body. It needs 3,000 to 8,000 shocks depending on how bad the erectile dysfunction is. Concomitant problem like hypertension, diabetes, number of years the patient has had erectile dysfunction. So depending on concomitant problems, you decide how many treatment sessions and how many shocks you would require. And then at the bottom, simple treatment, effective, harmless, very safe, and useful. Uh,
There is no audio.
oh, there's no audio.
Yeah.
Oh, I'm so sorry. I will stop this if there's no audio. What it's trying to say is it was used in orthopedic, it was used in previously urology, orthopedic, and erectile dysfunction. And then it unfortunately, you can't hear the audio, but there are studies which have been, they have done studies with many different equipment with different number of sessions, and the total amount of energy required. Other than sessions, it's important is to know the energy requirement. This is not what I'm going to discuss today, but it has the way there are techniques. How do you use it? These videos you have already seen, and it has shown to be a very effective therapy in management of erectile dysfunction. Okay, so what is in store for physiotherapists? I think there is more learning. There are new horizons to explore. Women health, we are almost there because uh, professionals like Dr. Sunita has been doing a lot of work on women's health, incontinence, training people, teaching them, making them aware of a lot of other stuff. Men's health, let's do it. I think this field is really exciting. It's really opening. A lot of men will suffer more because stressors are increasing in life. with having, more demand at work. So I think this field is going to explode, and that's where a physiotherapist should take more role in it. Physiotherapists should conduct studies and publish on this men's health, and I think it'll become ours. Okay, I finished my presentation. Thank you. If you have any questions, you may shoot.
Thank you so much, Dr. Sandeep. It was like, this is what I really want men's health to come up also.